So you get more time with your family. You never spend time with your family. You're always out.
Yes.
I will write to them and I will complain.
Okay.
Lim, how are you?
I'm okay. How are you?
Good. Good to have you here.
Thank you.
It's wonderful. Oscar said he will be delayed. He got stuck in an emergency surgery, so he will be delayed. And Nicolay, for whatever reason, is not picking up the phone. So I think no problem. We can start. Are we still on recording? Right? Okay. You know, there is obviously with two of our friends, they're well known all over the world, and they're well known for their endoscopic work. You know, Kim has been a dear friend for over 10 years now, and he's been involved in a lot of workshops, conferences along with them. And, you know, we have been involved in teaching training over the years, and it's really my pleasure to have both of you here. And so today's webinar is actually a webinar from Korea. So I'm grateful to both our Korean friends who are going to be teaching us how to do all this endoscopic that we do a lot of openly or with microscope. So I'd like to request Hyung-Sung Kim to start his talk, and he can share his slides first. Kim, please carry on.
Can I start? How much time can I take?
You have 30 minutes.
30 minutes only. Okay.
Yeah, I don't want you to operate. I want you to teach.
Okay. Thank you so much. Thank you so much, Professor Mashar. Very honored to give a talk in the International Pakistan Society of Neurosurgical Society. Today, my topic is the transforaminal. Salman only make a name transforaminal. Transforaminal meaning the transforaminal endoscopic lumbar discectomy. Yes, this is my curriculum by 10 disclosure. Yes. Okay. Firstly, why we should doing the endoscopic spine surgery? That is very important because last several decades, so many spine surgery developed, and also minimally invasive spine surgery also developed so much. But because of that, so many surgeons still worry and still have some question why we performing the endoscopic spinal surgery. Fortunately, during last several years, the endoscopic spine surgery developed so much, and you can see here that it can classify as a four generation. First generation starting from late 20th century, and the first we started as a transforaminal approach, and second generation. Next, then the second generation of the endoscopy intraminal discectomy developed, and also nowadays endoscopic decompression surgery and fourth generation of endoscopic fusion surgery now ongoing state. Because of that, the first things of the first generation of the transforaminal approach is very important. Maybe first generation of the endoscopic spine surgery started from the Professor Tony Young, and he firstly proposed the he proposed the visualized operation of the endoscopic spine surgery, and also because of his concept of the endoscopic spine surgery should doing the as a really minimally invasive approach to decreasing the all structures related to the spine, to decreasing death structures. That is a real rationale of the endoscopic spine surgery, and because of that, the transforaminal approach is a real rationale of the endoscopic spinal surgery. And then this is my paper for the percutaneous endoscopic lumbar dissection for all types of lumbar disconnection, including in severe difficulty and extremely difficult of lumbar disconnection cases. In my cases, if we learning and developing the transforaminal and also intraminal then we can manage the near 96% of the good to excellent result, including all types of lumbar disc herniation. It's meaning that we can give the more good clinical results to the patient in spite of the severe difficult and extremely difficult cases of lumbar disc herniation compared to the previous or conventional open surgery. And also this year, one of very remarkable paper published in at this year, Dr. Chen published the paper of the complication rate of the different discectomy technique for symptomatic lumbar disc herniation. He writing the paper of the systemic review and meta-analysis. In his conclusion, compare with the open discectomy, result of this meta-analysis suggests that PL has a low risk of overall complications and a low risk of complication necessitating conservative treatment. It means that Dr. Luque talking that this we really finally facing the chance of gold standard for disc herniation. It means that now the gold standard of lumbar disc herniation surgery changed to lumbar disc endoscopic lumbar disc discectomy rather than the open lumbar discectomy. And also this paper already accepted in neurology India. I compared the how we can expand the indication of the endoscopic spine surgery. In this paper, we can see this generation 1 lumbar discectomy generation, and generation 2 lumbar decompression generation, and generation 3 nowadays we doing this lumbar fusion generation. In here we can see the near 75% of degenerative spinal disease patient can treated under the endoscopic discectomy operation. It means that in spite of the so much increasing the degenerative disease with the increasing the mean life, we can still have a good treatment to the patient with the endoscopic approach, especially among them the transforaminal approach is a very important portion to expanding starting and expanding the indication of the endoscopic spine surgery. Yes, what is the rationale of the endoscopic lumbar discectomy and endoscopic spine surgery? Actually, he is this photo taken yesterday. He's a spine surgeon, spine neurosurgeon. He enjoyed the golf very sufficiently. He satisfied his life. Actually, he received the transforaminal endoscopic lumbar discectomy by me 3 years ago. It's meaning that if we give the more minimized, more less damage treatment to the patient have a more chance to his return to normal life. Yes, because of that, we should checking the what is the rationale of the endoscopic spine surgery, especially transforaminal approach. In the early period of the endoscopic lumbar dissection period, we believe that the rationale of the endoscopic transforaminal approach will be the early recovery, early ambulation, and less anesthetics and some cosmetic effects. Yes, it's true. We can take a more good early recovery and early ambulation and less anesthetic result to this patient. But nowadays, we performing more wide indication of the discectomy through the transforaminal approach. For example, this patient of the 37 years old male patient received several years of the open microresectomy, and after then he came with the severe pain with the weakness. In this situation, we if we can give the transforaminal discectomy for this patient and take a successful treatment without damaging another structures, we can give a really less damage the anatomical structures with the younger patient, and the patient can have a more chance his spine with his normal life. And also you can see here the 30-year female patient. You can see here so severe disconnection of the right side and left side and upper and caudal, cranial and caudal. In this situation, if we choose the open surgery, sometimes you need a fusion surgery, but this patient only 30-year, very young female patient. Because of that, if we can treat this patient transforaminally without damage the structures, we can give the real return to normal life to the patient. You can see this post-operative image, and we can give the preserve the motion segment to this patient. Then the patient can have a chance to return to his normal life. And also this patient, only 20-year male patient with the caudal equina syndrome, it's very severe great weakened state. In this situation, the patient should treat it with wide decompression or fusion surgery in spite of the only 20 years. But if you can give the real transforaminal approach to these cases, we can really preserve the neural stream with the preserve the functional segment for this young patient. It means that the patient can have more chance to his normal life. The patient for more than 1 year, he returned to his normal life. And also, in like this is highly inferior migration cases and highly superior migration cases, we several times met for this patient. If we doing the open surgery, the patient have less chance to return to normal life. But if we go doing the endoscopic transforaminal approach and give the good clinical result and good surgery to this patient, we can give the more good chance to the return to normal life. Yes, we first will be checking the history of the historical consideration of the transforaminal endoscopic lumbar discectomy. Yes, we already knowing that the first proposal of the Cambin safety triangle proposed by the Parvij Cambin. He detected the safety space from the posterolateral area made by the exiting nerve root and traversing nerve root and upper end plate of the lower vertebra. He mentioned this triangle as a Cambin triangle. Then we started the first time arthroscopic approach. Then actually, in spite of the knowing this Cambin triangle, first we visualize the approach to this Cambin triangle starting from the early 21st century by the Professor Tony Young, and then the endoscopic transforaminal approach developed abruptly, and so several kind of transforaminal approach technique introduced then. But nowadays we can classify the transforaminal approach from the inside out approach and then outside in approach. Then firstly proposed from Tony Young started from the inside out approach. Then 2005 Thomas Sugland proposed outside in approach because of that the internal debulking or internal destruction also have a chance of some destruction of the segmental instability because of that. Sorry, because of that he proposed outside in approach, and nowadays we divided two approach technique of the inside out technique and outside in approach. Actually, this outside in approach have a more chance to some to the target point, but there is some need some learning and some instrument. But maybe 2 years ago, I proposed that some mobile outside in transforaminal approach. I published this paper in Jove. It's meaning that some mixture of the inside-out technique and outside-in technique. We hope to approach to the all kind of target of lumbar disc herniation from the transforaminal approach, but inside of the approach have some limitation of the bony obstacles to the target point, and the outside-in approach also need some destruction of the facet and some another bony structures, sometimes some danger to the nervous structure. Because of that, we give the some mixed type of this inside out approach and outside and approach, and can have some skill to the more easy approach to the target point. We can give the more successful surgical result to the endoscopic lumbar disc herniation by the transforaminal approach. And then now we should consider the anatomical consideration of the endoscopic transforaminal discectomy. We already knowing that this can be triangle, but there have some another important structures of the sympathetic channel of the sinovertebral lobe and vestibular lobe. Actually, this sinovertebral lobe and vestibular lobe connected to the dorsal ganglion, and it connected to the sympathetic channel. Because of that, it related to the chronic discogenic pain and some chronic change of the pain in the spine. Because of that, this sympathetic connection is very important. Also, this connection related to the dorsal ganglion. And also here we already knowing that this transforaminal approach through the exiting nerve root and the lateral border of the facet. Because of that, it is not close to the target point of neural structures. Because of that, last year some doctors are doing some extreme lateral approach, but there is some we should checking here. What is the safety point of this angle? You can see here. This is safety angle. It means that 20 degrees or 30 degrees is safe, but the less angle approach is direct approach is sometimes danger, because it have some chance of the visceral organ damage or sometimes the exiting nerve root damage. Because of that, if we hope to lessening the angle from the through the transforaminal approach, we can firstly docking this steep some safety angle, then lessen the angle like this. Then we can take a more chance to the close to the target point of neural structures like this. This is a concept of mobile outside-in approach. Then also sometimes nowadays endoscopic drill or drill or reamer developed so much. Because of that, there have some obstacles of bone structures we can more easily approach to the target point. You can see this paper is an old paper. Because of that, this several years ago we knowing that there have some very difficult cases of the approach like this high canal compromised cases, but highly migration cases. But nowadays this is not difficult. Because of that, nowadays the endoscope drill developed so much. Because of that, if we hope to approach more some highly migrated cases or some high canal compromised cases, we can more easily approach to the target point using the endoscopic drill. And also in anatomically, there in the transforaminal area, there have some another very important structures of this segmental artery. Actually, this segmental artery arises from the aorta, and it passes beneath and over the dorsal root ganglion. It means that the rupture is close to the ventral of the dorsal root ganglion. Sometimes some chance of the segmental artery injury, or some dorsal part also sometimes danger, but this area is more danger. This case is my case is of a huge retroperitoneal hematoma after segmental artery injury. But if we knowing this anatomical structures and we checking the huge vigorous bleeding, huge bleeding during the operation, we can check this point, ventral point of the dorsal root ganglion, then coagulation and some control the bleeding to there, then we can check decreasing the retroperitoneal hematoma. Actually, I think that maybe I have more than 3,000 cases of transforaminal approach. Actually, this case met 50 cases. After checking this point of segmental artery injury, after then I have no cases of retroperitoneal hematoma cases, only one case. Yes, and the transforaminal approach, we should checking another, these three different anatomical approach route. This route knowledge already published in World Neurosurgery Journal. There, you can see checking that this there in the transforaminal area, we can see the this intervertebral root and this foraminal root, and also this suprapedicular root. Why it is different? Because of that, actually, like some transforaminal inside out technique, usually we approach to the intervertebral root, but that time the move to the foraminal root and the suprapedicular root is not easy. Because of that, we should checking this some different characteristics and different route of the transforaminal, three different routes. You can see here the paratraal disc and foraminal disc and superior migration related to the dorsal root ganglion, and it should approach through the foraminal route. But in the highly migration cases or some paracentral inferior migration cases, need some suprapedicular route. It means suprapedicular route meaning that you need sometimes some drilling of the bone structures around the suprapedicular area. Here is a 30 different root anatomical structures. This intervertebral root and this foraminal root we can see like this shape, and sometimes we can see some axilla area of the transforaminal space. And this suprapedicular root can see the suprapedicular notch here. Then we can approach to the target point. Then you can see intervertebral root. Usually, we for beginner and so many doctors firstly docking the intervertebral root, but sometimes we move to the foraminal root like this, and there we can see some axilla and dorsal root ganglion, and should checking the final free space of the axilla is the finish of the foraminal root approach. And also suprapedicular root also from move from the intervertebral root. It's meaning that first docking to the canvas triangle and move to here. Then we can see this suprapedicular notch. Then some drilling or some exposure there, we can approach to more highly inferior migration cases. Then we can firstly docking, but sometimes we need the foraminal approach. We need some change the angle and go through the foraminal route. But sometimes we need some highly inferior migration cases, some change the angle to the attached to near to the suprapedicular area, and sometimes some drilling, then pass through the abdominal space through the suprapedicular route. Okay, and now we can see the Professor Salman. Okay, now we're going.
Yes, Kim. Yes.
Yes. Kim. If finish time, give a message to me, okay? Because
okay.
I have so many slides here.
You have got 4 minutes to go.
4 minutes?
4 minutes.
4 minutes.
4 minutes. 1, 2, 3, 4.
Okay, I'll give a talk only 4 minutes. Yes, nowadays we doing the several kind of anesthetic method, local anesthesia and after anesthesia, some general anesthesia. In the transforaminal approach, usually use the local anesthesia, but recently I like after anesthesia with the sedation. And then, yes, this also very important anatomical structures, because the starting point also very important. This image is very important. The safety point of the back muscle and abdominal muscle starting from the lateral border of the iliac crest with some oblique and straight, through this line, we can make a safety of this transforaminal approach route here. And then we're going through this shape. And also should targeting the low targeting this area first in the first docking, lower and most posterior border of the disc safety triangle. This is, if it possible, should target this area, because you can see in the X-ray, you can see like this image, because this area sometimes some danger. Okay. Yes. Then nowadays, I'm also so many recently paper hope to overcome the learning curve and approach to the target point near all kind of this condition. Because of that, I recommend the mobile outside approach. First, docking the foramen and move like this, and also move like this. Firstly, docking and move. Then you can see here. The same step, but mobile outside only docking to here, not inserting discal space. Then you can docking the transforaminal space. First image, you can see that this annulus. Then you can see the some mobilization of the working channel to the target point. Yes, in the okay, there have some tips of the some overcoming the learning curve. This is very important because I will some comment that we already knowing that the inside and outside in approach. But if we hope to move to the target point, outside in approach is more easy because it some change the working channel is more easy, like this mobile outside in, like this, and also. At the first docking to the in the docking point is more deeper point of the canvas triangle here. Then you can first we can see that this annulus after clearing, you can see this shape, this clear. Here you can see the some docking here and some change of the working channel and move to the target point. This video is very important. If we hope to here move and move. Can you see again? Docking and move the working channel. Yes. Then we can see like this approach, and also can lessening the angle. Okay, I wish in the some another tips of the overcoming the learning curve is this vertebral overriding technique. In the especially highly inferior migration, highly superior migration cases, they're first docking the working channel and then, sorry, again, rotation and overriding the working channel to the target point like this. Again, like this. Insert, rotate. Yes. for high inferior migration. This for high superior migration cases to the docking, rotate, overriding, and go through the frame. Yes, in the transforaminal endoscopic spine surgery also have several complications. Among them, 3 complications is very important. One is dural tear. Dural tear can easily, not easy, but anyway, can managed by the patch blocking technique. This technique already published in World Neurosurgery Incidental Durotomy paper. You can see, read here, like the patchy. You can see the so huge dural tear, and yes, then 6 months later, the patient have wear return, wear restoration, and also some another complication is the segmental artery injury. Also, this also very important to checking the segmental artery. The finding the segmental arteries is very important. Some another important complication is infection. To decreasing the infection, I'm always recommend to my nurse to keep the final tips to the working channel like this. This is very important from the instrument to insert to here. Not touch some because this instrument always very long and have a more chance of the touch the infected material, because this is very important. Yes, I will find out is the some of cases. This is already well known. I'll pass briefly these extraforaminal cases, post-operative. This highly inferior migration cases with suprapedicular circumferential opening, meaning that some suprapedicular lurch drilling, sometimes some this vertebral body drilling, then expose this space, then can take out. Okay, record cases also can possible transpedicular suprapedicular root, high canal compromise cases post-operative. And this L1-2 foraminal to superior migration cases also can possible with a transforaminal route. And some pending neurology state to have more chance, more advantage in the transforaminal route, because this is a less neural retractive approach. As more chance to return to his he or she's recovery of a neurologic damage. And this intradural rupture, this case is also can possible transforaminal. And 5S1 transforaminal approach can possible. And now this also can possible thoracic disc herniation through the transforaminal approach. Yes, in conclusion, I think that maybe now this lumbar disc herniation can possibly, all kind of lumbar disc herniation can possible through the transforaminal approach and intraminal approach. Among them, the maybe transforaminal approach occupied more than 70 or 80% of the lumbar disc herniation approach. And I'm also recommend to overcoming the learning curve, the mobile outside approach more have a chance to overcome the route. And also you should checking there have 3 different routes. And also I think that maybe endoscopic, especially transforaminal approach, have a real minimized option and real target oriented surgery treatment. Thank you for your kind attention.
Thank you, Kim. That was excellent. Really enjoyed that. I think what we'll do is we'll ask Lim to carry on with this talk, and we can have discussion at the end. Nikolai, do you agree with that?
Yeah,
Nikolai,
completely. It was very comprehensive lecture, and I really enjoyed. But due to time, yeah, I think let's leave the discussions at the end.
Do you want to invite Lim, please?
Yeah, okay. So it's my pleasure to invite Professor Lim to deliver his lecture. I'm sure it's going to be very interesting as well, and we will learn a lot of new things. Professor Lim, please.
Kim, you have to
You can
unshare
share
your
your screen
screen.
now. Kim, probably you have to stop sharing. Yeah.
강태기 밑에 있는 슬라이드 쉐어하세요.
Yes, Professor Lim, now you can share your screen. We can start with your presentation. Thank you.
And please unmute yourself.
소리가 꺼져 있어요, 소리. Dr. Lim, yeah. No. 소리 안 들립니다. Your sound off. We can
Lim,
hear your sound.
please unmute.
Unmute.
Are you doing it?
Hello.
Okay, good. Yes,
Yeah.
Lim, we can hear you.
Yes, we
Okay.
can hear you now.
Okay. How are you, everyone? My name is Lim, a neurosurgeon in Korea. Thank you for the kind invitation to present the endoscopic job to such a wonderful meeting. Coronavirus pandemic is spreading. Like wildfire is a challenge the humankind has to overcome every now and then. We don't know when this condition is going to end. Peace be with you. I will talk about the functional role of endoscopy in spine surgery. The microscope in my hospital is retired already from the main operation of spine. I think you may think this is a joke, but it's a real situation in Korea as a development of endoscopic science and technology and its instrument. Endoscopic process can replace microscopic functions. Actually, we don't need to perform open surgery in spine anymore, except deformity correction in my hospital, because we can do endoscopic decompression, endoscopic fusion for lumbar and cervical. You know very well this the movie released in 2005, War of Worlds, starring Tom Cruise. So you can find the ideal endoscopy that we need to pursue with a high image quality that will ensure safety during the operation. Ideal endoscope system that should be like this, the less damage of
Sorry, Lim. Sorry, Lim. Please share your slides. We can't see your slides. You have to share your slides, please.
Steerable operating the narrow space. It's okay.
No, so you need to.
슬라이드를 공유해 주세요. 밑에 화면 공유를 누르세요. 화면 공유. 파랗게 보이는 거.
안 뜨는데.
Just click on share screen at the bottom. You see in the middle of your screen, it says share screen.
밑에 보면 화면
green color. Green color.
안 떠요. No, I cannot see the green color.
Green color in the middle next to the chat. Down at the bottom. Lower down. Kim, can you please guide him?
Okay.
안 떠요. So I cannot see the green color.
There is a thing at the bottom where it says participants, poll, chat, screen share, reaction, bottom, lower down, lower part of your screen. Yes, at the bottom in the middle. You can't see any green color on your screen? A tab with a green color.
I send the KakaoTalk to you.
안 보여. I cannot see it.
그럼 나가셔가지고 그 줌을 다시 들어오세요. 지금 화면 공유가 안 되거든요.
If he asks him to bring the cursor down, it will appear if it's not there. Ask him to bring his pointer down to the bottom of the screen. Lim, can you bring the pointer of your computer down onto the bottom?
Okay, it's okay.
Yeah, that's brilliant. So you're there.
Okay.
So you need to find out where your presentation is and click on it.
Can
Where
you
is
see
your
my-
presentation? No, we can see the Zoom meeting, but we should be seeing, your screen is on the other side.
화면 공유를 누르면 슬라이드 미리 띄워놓은 것이 보여요. 그걸 누르셔야 돼요.
Can you make your, this particular screen you're seeing, make it small? Please make it small. Minimize this screen, please.
ESC를 누르시면 저거죠. ESC.
Please minimize the screen first.
Okay,
Then you should be
minimize.
able to see your slides.
아니
Minimize is right.
보드판에 ESC를 누르면 적어지거든요. ESC. 밑에 자판이에요, 자판.
How do you minimize any file? Just minimize it, please.
Okay, minimize.
It's not. There is a dash on the right top corner. Yes, that's it. Minimize it, please. Press.
So,
Press on that. Lim, you need to press that.
this one.
Yes, please press.
Start.
아니 지금 슬라이드 안 보여요. 줌밖에 안 보여요. 인터넷밖에 안 보이거든요. Alt S를 눌러보세요. Alt S.
So you need, if you just minimize this, then we should be able to see your slides. Are you using a
Alt하고
Mac?
S
Okay.
눌러보세요.
Kim, can you help him minimize or change the screen?
Okay, minimize.
네, 그건 아닌데. 그건 내려보세요, 한번. 내려보세요.
Okay, what you do is probably the best
Push
thing
it,
is
push
that you switch it off, just close the screen and reconnect. If you reconnect, should be okay.
Okay, 공유 다시 시작.
How about on the left top corner? Are those your slides on the left top corner?
바탕화면에 모니터를
Yes, now he's minimized. So can you minimize it further? Just take it down.
Okay.
Drag this down so that you can see
내리세요,
your slides.
내리세요. 인터넷. 네, 이제 지금 여기 누르면 돼요, 거기서. 강의 슬라이드. 네, 됐습니다.
Yes,
That's okay.
so you can
이제
open up your
됐어요.
slides.
Okay,
Where are your
okay.
slides?
Brilliant.
Very good. Thank you. Let's start. Good job.
Okay. It's, can you see
Yes, and I like the punch.
okay. It's not easy. I don't know why. Okay. From the first. Okay.
Yes, please.
Okay. The microscope in my hospital is retired already. Can you hear me?
Yes, we can hear you well.
Okay. Okay. So you may think this a joke, though, but it's a real situation in Korea. As a development of endoscope science and technology and its instrument, endoscopic procedures can replace microscopic function. Actually, we don't need to perform open surgery in the spine anymore. except the deformity correction in my hospital, because we can do endoscopic decompression, endoscopic fusion for lumbar and the cervical also. And you know very well this movie, the release in 2005 of the World starring Tom Cruise. We can find the ideal endoscopy that we need to pursue with high image quality will ensure safety during the operation. The ideal endoscopic system should be like this: less damage of structures, framework, with a steerable application ability in narrow spaces, like this. So I think in general, the goal of a minimal invasive spine surgery is to stabilize the vertebral bone, the spinal joint, fascia capsule, and muscle ligament. It has to prevent instability, degeneration more post-operatively. Among the many possible approaches to reach the spinal canal, the endoscopic view, the way is most effective in treating spinal pathologies with few risk. Approach to the fatty atrophy between spinal muscle and the spinal process without muscle detachment from the spinal process will guarantee less damage of paraspinal muscle and ligament around the fascia joint. The skin incision with number 10, the surgical blade, just beside the spinal process, enable the passage working channel, the endoscopy, and the surgeon can perform the decompression, the multiple level stenosis, like this, with one skin incision. The surgeon got to compare tubular and endoscopic process about skin incision and muscle damage, but endoscopic system will have a lot of valuable advantage, like a small skin incision, and endoscopic surgery is superior than tubular system for the skin incision. And outstanding, the advantage application ability will be better than tubular system that will properly equipped for anything in any situation with a clear view to preserve normal anatomical structures. So I will tell you more detail about application ability, the steerable characteristic compared to tubular retractor system, and the endoscopic approach is much more convenient for ipsilateral decompression with a minimum bone work of fascia joint due to stability like the drone. If you want to see the anchor with the tubular retract, the belly, the fascia joint will be big obstacle to see anchor. So we need to cut the belly, the fascia joint more to see anchor ipsilateral nerve. The endoscopic, the surgeon were obsessed to have ideas for just one pathology for a long time. So we spent a long time to solve just one pathology with transforaminal approach for discectomy and interlaminar approach is just one level, the laminectomy and flavectomy. But endoscopic standard have reached new level. We can do 3-level lumbar cervical jumping or sliding technique, and we can do performing the endoscopic, the procedure for multiple combined lesion, and we can do a 3-level interlaminar approach and the paraspinal 3-level with one skin incision at the same time. So it's the multifunctional role of spinal endoscopy. New endoscopic system were designed to use in spinal stenosis. You can use 1, 2, 3, 4, 5 millimeters calcium punch. And although it's a narrow, the laminar surface, very narrow, the 4 millimeter, 10 millimeter. And then the rotate the spine endoscopic system have proved to be one of the most effective ways saving facet joint. Post-operative CT scan shows preserve the facet joint. And post-operative MRI shows no damage of the facet joint and paraspinal muscles. The starting point is spinal laminar junction and the laminectomy and the SAP and the upper lamina. And finally, we can decompress ipsilateral root. And it's bilateral decompression and the point of decompression. We can find the ipsilateral excellent shoulder and the contralateral side, ipsilateral contralateral side, excellent shoulder. And you can see the complete bilateral decompression and it's at the midline. And you know the very well advantage of the endoscope surgery, Dr. Kim said already. So I will talk about complication, the root injury, radial facet fracture, bleeding during the procedure, infection, post-operative hematoma. But most of the surgeons are scared about the dural injury. So I think the best way to treat the incidental dural injury will be the in endoscopic procedure can be using taco seal. Can you see that this the dural and root strangulation? And using taco seal, the taco seal is a fibrin cylinder patch. So I have no chance to open dura repair for less than 4 years. We got them clear up all case of dura injury. The first one layer, the taco seal inside, and then one more layer, the outside. One more, 2 more, 3 more. So we can use a taco seal. Okay. So, but there is no infection, the post-operative endoscopic process, and sometimes we have a post-operative hematoma, so we need to keep the drain just for the 1 day. And the bleeding control is very important. And we need to suppress systolic blood pressure less than 100 mercury, and the water irrigation pump should be kept 40, 60 the mercury. And to control after bleeding, we can use radio frequency and the bone bleeding. So we can use a calcium punch. You can compress cancer spawn firmly with a calcium punch. We can control the bone bleeding like this. It's very easy, right? You can use a cancerous one. Yes, so the case, the patient have L45, the autofusion already, and just the patient have radicular pathy leg pain. So we need to decompression only. Pre and post operative MRI shows full decompression. So we can do ipsilateral and the contralateral side, the decompression with the endoscopy. It's in case of a multiple level, 3 level, we can use a jumping technique, can use elasticity of a skin, and we can do the 3 level decompression with the 1 skin incision. It's a patient have a 3 level severe stenosis, pre and post-operative, and post-operative, the MRI shows a full decompression. But we can use 1 skin incision, and we can insert the drain to prevent post-operative hematoma. And the next day, patient can work with 3 hand grenade. And also the 3 level 2, 3, 3, 4, 4, 5 pre and post operative shows full decompression. Actually, the image shows the enough full decompression. It's my paper about the 3 level decompression with a single skin port. And some patients have the 5 level. You can do with a 2 skin incision. You can do 5 level the decompression with endoscopy. Some patients have the 2 pathological lesions not next to each other. So we can reach to the epidural space to each level 2 pathological lesion with a jumping technique. And the HYEUN cluster, you can do discectomy. So without any the blue stain. And for the foraminal stenosis, the herniated disc is different between the transferal approach and the proximal approach. As the 6 or 7 centimeter distance from the midline, we can make obtuse angle the parallel direction between root endoscopy will guarantee the safety of exiting root and then the transparent approach. The landing point is the pulse, and the post-operative CT scan shows full decompression. And the endpoint of a proximal approach is to expose exiting root and inside, traversing root inside and exiting root outside, and a disc space after resection of the superior process. It's exiting root, and then we can remove the foraminal disc with endoscopy. Okay. And as I mentioned, the jumping technique, the 3 level, the paraspinal approach for the 3 level foraminal stenosis with a 1 skin incision. The first midline first, middle 4-5, and we can use skin elasticity. Then we can jumping down L5S1 for foraminoplasty and L3-4. Okay. It's my paper about multiple level decompression with 1 skin incision for foraminal stenosis. And sometimes we can do the contralateral approach for the decompression, central and lateral recess, and the foraminal stenosis at the same time, like this. So let's move on to next the endoscopic function. Another fusion surgery in case of the radicular faith. You can do try the decompression only, but the patient have motion caused back pain with spondylolisthesis. It's good indication for the endoscopic fusion. It's a 64 male patient have a motion caused back pain, and the post-operative X-ray shows the transforaminal approach, the fusion surgery, and we can expose traversing and exiting root after resection of the facet joint, and we can expose traversing root and exiting root and disc space. Motion caused back pain, female patient, post-operative. And you can use the 3 printed porous titanium alloy cage. It's just the small skin incision we can do with just this one skin incision. We can do the facetectomy and discectomy and cage insertion, pedicle screw. So 1.5 centimeter full hole is enough. And full the process. Full endoscopy means all process was by endoscopy through the endoscopy, discectomy and shave, allowable graft, cage preparation, the endoscopic, the assist cage insertion. The one of the advantages of endoscopic fusion is the less bleeding. You can find all anatomical structure during the operation. So after the resection of total facetectomy, and you can do contralateral side of facetectomy also. And then the end plate preparations. And the surgeon can insert endoscopy more, little more to the contralateral side in disc space, can make more the space for bone graft area than the open tree. Endoscopic fusion has been performed under the local anesthesia and the mask sedation. And we can expose trabeculation and external and disc space. It's endoplate preparation, the allowable graft, cage insertion. We can reach to contralateral side. It's the cage, pre and post-operative. The interbody bone graft area should be greater than 30% of total end plate area to provide enough contact area between vertebral body and cage. So data is estimated that fusion rate is almost same, and but I think we need to check long-term follow-up to know the outcome, the fusion rate. It's my paper about bone graft area and fusion rate with endoscopy compared to mini open procedure. And so on to the next topic, the cervical, the endoscopic role of a cervical lesion or decompression for foraminal stenosis and foraminal and paracentral hernia disc, and endoscopic HDF for myelopathy and ADR for central disc. We can do the foraminectomy, laminectomy, discectomy with the posterior approach for foraminal stenosis, paracentral disc, myelopathy. And for the central disc and with the myelopathy and the OPLL, we can do anti-approach, the HDF with endoscopy, and we can do ADR. It's the endoscopy posterior approach, foraminal and discectomy with the posterior approach. And with the sliding technique, we can do 3-level decompression for foraminectomy. It's a C45, you can say C5 root decompression, and the C5 the lamina, and we can move into the C5 or 6, C5 central decompression, and we can see C6 the root, C6 root, and we can move into the C6-7 for C7 root decompression. It's a sliding technique, and in case of myelopathy, the ligand flavum compress the thecal sac, thus we can decompress the spinal canal with the endoscopic posterior approach. It's a video, it's a C5 root, and then You can see C45 midline and contralateral side. It's full decompression. MRI, post-operative MRI shows full decompression. And we can approach in case of a rheumatoid panus arthritis C1, 2, patient have a C2 root symptom, the headache, pre and post-operation, the MRI shows decompression and CT scan also. We can reach to the C1 region with endoscopy. And it's the video, you know, the panus is abnormal layer of fibrovascular tissue and the granule tissue. We can remove this the panus tissue, and we can see C2 root decompressions. And ACDF, so we'll talk about endoscopic ACDF now, the skin, the scar post-operative endoscopic, just the 1.5 or 2 centimeters enough. And pressing against the anterior cervical organ with the index finger, we can reach to disc space, and we can touch disc space between carotid and hyoid bone, and endoscopy, serial dilator, walking sleeve, and endoscopy. And we can use some instrument to drill and punch. And finally, we can insert the 5, 6, 7 millimeter height the cage. Some doctor asked me how to insert the cage into the disc space. It's the cage, the hold. The first, we need to insert the cage hold, and then you can set the cage, and we can insert the cage under the endoscopic view. Okay, it's a case during the operation. So we can see no bleeding, discectomy, and we can see the dura after removal PLL and the KG. Okay, next case is a young male patient have myelopathy C 5 or 6. The first, you can reach to the anterior surface of a disc and the discectomy. You can use a drill or punch, and we can remove PLL to expose dura, and we can insert cage with endoscopy. It's the final endpoint of this process. We need to keep the drain to prevent the post-operative hematoma. And you can see the esophagus and trachea ran away from the midline their space to safety to contralateral side, and we can use the punch to remove the posterior osteophyte, post-operative X-ray, MRI. It's full decompression with a small scar. Post-operative 6 months, the follow, the stable, and very important thing is keep the drain post-operative. The 1 day to prevent hematoma is very important. And the ADR is the same, like the HDF C6 central discal detonation. So we can insert needle and endoscopic, some instrument, and discectomy with endoscopy. And we can use the drill to remove posterior osteophyte. That's PLL. So you can see the pulsation of dura, the measurement of disc height, and then we can insert the ADR drain. Also, operating MRI shows no prevertebral swelling. X-ray. Okay. It's my it's my paper published in India for endoscopic HDF in last year. In conclusion, endoscopic surgery has a multifunctional role in the spinal pathology and will continue to grow and evolve with the development of science and technology in various ways. We just don't need to it all right now, but it is a time to think ahead and to prepare for the future, the endoscopy. Thank you.
Yes, Nikolai.
Yes, so it was impressive indeed. Everything was really interesting, and we have seen presentations which demonstrate a lot of confidence in the area that we don't see with many. And I've seen really interesting things, and although I started doing these things myself, I think that Kim and Lim, they are way ahead, and they showed us very interesting presentations, which we have learned a lot from. And congratulations for your good results. I was very happy to be part of that and to see them.
Thank you.
I think both Kim and Lim gave excellent talks. I think both the talks had genuine material in them, and very good tips, especially for the learning curve, which is the most important thing that I feel. And many people start and then they realize they have residual disc or recurrent disc and back off, and they start this off. So Kim, what is your way of ensuring that when young people are starting out, what is your trick to ensure that you do not get a recurrence or a residual disc?
Recurrence.
Yeah.
For recurrence. Actually, in the recurrence of the endoscope, transforaminal discectomy have a 2 points. Most important point is successful surgery. It's meaning that so actually the endoscope transforaminal discectomy is not temporary procedure. We should doing the complete surgery, then we can decreasing the chance of recurrence. Actually, in the early recurrence, usually related to the incomplete discectomy, because complete surgery is very important. Second things, that if we doing the complete surgery, we should give us some more limited, restricted severe highly activity of life. It means that some limitation of activation, exercise, and if it's possible, recommendation of bed rest more than 2 or 4 weeks. And the patient can possibly return to his normal life, but if it's possible, limitation of the life. There's a very important decrease in the recurrence.
Okay, Lim, is that your experience as well, to give them initial rest as well for 2 to 4 weeks in order to reduce recurrence?
Sorry, I can hear you. Sorry.
Do you have the same experience as Kim?
Yes.
In which you ask people to have a 2 to 4 weeks rest before they go into active lifestyle?
Yes.
Okay, all right. So your recurrence rate for transforaminal discectomy are like what? What percentage is your recurrence rate?
The same like the Dr. Kim does recommend, and add. So it's very important thing is the approach is very important. So approach is where the make the incomplete operations is very important. So some beginner choose the easy way to remove the disc. But the patient have has the combined lesion, the disc and the stenosis. So we need to consider this. The first diagnosis and approach is very important to reduce the recurrence rate, I think.
Okay, what about fusion? Like, your endoscopic transforaminal, lumbar interbody fusion. So my question is endoscopic, like what's your indication for doing endoscopic and what's your indication for doing MIS?
Indication is the same, like the open the microscopy, but the advantage of endoscopic the fusion is we can make the more space for the bone graft area. It's very important to can ensure the high fusion rate, I think.
Nikolai, you have any questions for Lim and Kim?
Yeah, I just wanted to ask a few questions as well. So, question 2 is about the type of anesthesia that they're using. My personal approach, although I have way less cases than they have, when I started initially, I started I didn't to do this under general anesthesia. Hello, can you hear me?
Yeah,
I think can you go again because we lost you there.
Okay, so my question is general anesthesia versus local anesthesia. I was saying that initially when I started my cases with local anesthesia, so I have the feedback from the patient, and because I was afraid of nerve root damage. But now when I got more experience, I feel more confident to do the general anesthesia. I'm talking about transforaminal discectomies. And the patient is not moving, and the procedure goes better and smoother and goes faster. What is your experience with that?
Yes, Nikolai, it's agree. Actually, in the beginning stage of the learning curve, it needed some local anesthesia because some of beginners have some more high chance of nerve damage, especially dorsal ganglion or active nerve root. Because of that, you need always checking the patient situation in the transforaminal approach. But if we have some experience, and I'm also same, I'm also epidural sedation. It's near similar to the general anesthesia. It's meaning that the complete sedation state, meaning that cannot checking the patient nervous situation, but it's meaning that you have some more experience of the endoscopic spine surgery. It's more decreasing chance of the nerve damage that is sufficient to general or epidural sedation anesthesia is sufficient. I agree.
Perfect. Okay, and the other maybe it's not question but comment. I would like to hear from you as well about residual disc. If you do transforaminal and if you leave small disc behind, for me at least, that is not a big problem as soon as the patient is asymptomatic. Quite often I see this, but I see some small piece behind, but after a few months, if you scan the patient, you don't see that piece. That piece is gone, so it's resorbed. What is your experience with that?
Nikolai, I cannot understand you're talking some disruption of the connection. Can you talk again?
Okay, repeat again. Yeah. So residual disc after you operate transforaminal, if you leave small piece behind, my experience is this is not a big problem as soon as the patient is asymptomatic. And I see that after a couple of months, if I do MRI scan, I see that this small piece is gone. It's not there anymore.
Yes, it's correct. Symptomatic disc usually related to the close to the dorsal root ganglion. No, nerve root, not center or
Yes.
close to the paracentral or close to the nerve. Because of that, we should checking the very cautiously close to the nerve root, but center usually cannot important some remnant disc, but some around the nerve root there is some of small point of remnant disc sometimes make a symptom because of the should checking there very cautiously, but center is not important. Yeah.
Yes. Yeah. Okay.
Okay.
Thank you.
There is a question. Nikolai, can you read the question from the chat? Can you see it?
Let me see.
Max, who is asking a question,
If I can,
and this is to Dr. Lim.
Let me see.
I'll read it. How to insert a cage back to the track where you remove the endoscopic working sleeve in ACDF or ADR? How do you protect the soft tissue when you're putting the cage?
To protect the soft tissue, anterior soft tissue, so we scale the damage of the anterior soft tissue, the esophagus, and the trachea is very important. But the first time when I tried this endoscopic diffusion surgery, I have one case of the esophagus damage. So because I didn't use the small retract to protect the contralateral side, the soft tissue. But now we can use small the retract to prevent damage of the soft tissue anterior.
Okay, brilliant. I think we really enjoyed that. Both the talks were very good. It was a good discussion. Enjoyed that. And hopefully we will have you in person here at some stage instead of virtually having you here. It was really our pleasure. We will just go. We have got, can you please share those slides? Yeah. So we have got International Psn Webinar number 38. And this is, we have Tariq Khan talking about neurotrauma guidelines in lower middle income countries. And then we have Tariq Imtiaz who's going to be talking about cranial neuromonitoring. And we have Franco Cervedi, President of the FNS, and Randy Chestnut as the moderators of this session. What else do we have? Okay, and for the next, to follow that on Wednesday 17. So this one is so Ramesh Nair and Oscar will be following that after a few days, but this is not the one that we have. But then we have on the weekend, we have Nelson, who's the incoming president of World Federation, joining in with Henry Schroeder, and we'll be talking about endoscopic skull-based surgery in that. And all are most welcome. Hopefully people who have filled the form will get the certificates, CME certificates for this. And Lim and Kim, obviously you will get your certificates as well. So thank you, it was a pleasure having you all. Just for last comments from Lim and Kim, and then we wrap up. Kim?
Thank you so much.
Sure.
Thank you very much.
You.
Okay, bye-bye.
Thank you so much.
Thank you, everybody. Thank you, Nikolai. Pleasure having you as always.
Pleasure being here as usual. Thank you, guys. Got wonderful presentations.
Thank you. Bye.
See you.
Bye.